Thank you very much for the kind introduction and the invitation. Good morning. I'm very pleased to be with you for this neuroimaging talk. So indeed, the goal is to explore the possible brain substrate of long COVID, not the whole long COVID, not for all the patients, but for patients with neurological symptoms. We aim to address whether brain dysfunction, so mechanisms so far largely unknown, might explain this symptom and be detectable at individual level with available tools of clinical imaging, with a possible value of biomarker not of long COVID, but of the brain impairment of long COVID. So we have first to mention that this hypothesis of neurotropism has been initially suggested for other virus and other coronavirus. So the lamina cribosa from the nose to the brain, where ACE2 receptors are strongly expressed, and then thereafter with transsynaptic progression. So brain impairment based on a network, on a specific network. By neurotropism, I mean the impact on the brain, on various possible mechanisms, viral, directly viral, or indirectly on immune hypotheses or brain inflammation. I would like also to mention the knowledge of other clinical models. Here, the model of the Parkinson disease, because in the Parkinson disease, the fatigue has been linked to apathy, to cognitive impairment, and to the olfactory dysfunction with exactly the same brain network of involvement and the two same pathways, suspected pathway of propagation. It has been said briefly yesterday, I think, by Nicolas, with two hypotheses. The first, the brain first hypothesis, from the nose to the brain and then the body, through the autonomic nervous system. It is a descending pathway, a top-down hypothesis, and alternatively, the body first, with the involvement of, for example, the lung, the gut, the gastrointestinal tract, and through the autonomic nervous system, then the brain. On this hypothesis of transmoidal pathway, the first cerebral node would be the olfactory region, which is strongly connected to the limbic system, to the amygdala, which is involved in emotion, to hippocampus, which is involved in memory, but also on brainstem nuclei, and then on the autonomic nervous system, whose dysregulation can explain many symptoms of long COVID. So we showed in this study 35 patients in comparison to 44 LC subjects, a brain profile of brain glucose hypometabolism. It is a statistical analysis at the whole level of the whole brain, but the results are limited to this specific network from the olfactory region, the frontobasal region, and the connected region, the limbic, the paralimbic system, the amygdala, the hippocampus, the cingulate cortex, the insula, the thalamus, the brainstem, and the cerebellum. And this profile of hypometabolism strongly differentiated patients from LC subjects. I will not have time to develop all the correlation we obtain between hypometabolism and clinical characteristics or symptoms, but globally, more severe hypometabolism was correlated with more numerous symptoms of long COVID. We had also a statistical association between a specific localization of hypometabolism and specific symptom of long COVID. And the second point I would like to draw your attention is that patients who were treated initially at the acute stage of COVID by nasal decongestant had afterwards lower symptoms and a better metabolism of the olfactory region. So what is the significance of this brain hypometabolism and for the understanding of long COVID? In the general case, generally, such abnormalities are considered to reflect neurodegeneration. I can give the example of the international biomarker classification that groups PET hypometabolism with MR atrophy. They are both considered as biomarkers of neurodegeneration, and hypometabolism is considered to be an earlier biomarker than atrophy. But it is important to add that this glucose metabolism in the brain is also strongly related to the function of astrocytes, to also the neurotransmission of glutamate, and it can be disrupted by neuroinflammation, by microglia activation. So we have two big hypotheses to explain brain hypometabolism. Again, it is the general case, but it is certainly true for long COVID. The first, hypometabolism is an early atrophy by loss of neurons, loss of synapses. It is a non-specific explanation, but related to a pathological processes. There is a lesion on the brain that will lead to neuronal death. The second hypothesis is, in my view, the major hypothesis for long COVID. It is the metabolic unit that is impaired, the astrocytes, the glutamate neurotransmission, because of neuroinflammation and microglia activation. And this neuroinflammation, this microglia activation, have been demonstrated on a preclinical model. It is a longitudinal follow-up of infected rhesus macaques using PET, but using a more specific target, a more specific ligand, the TSPO. TSPO is a mitochondrial protein that is expressed in microglia cells upon neuroinflammatory activation. And the same results are now demonstrated. It is a primary study on humans with long COVID, exactly the same PET imaging and the same target, the TSPO. And this neuroinflammation, this microglia activation were correlated to symptoms, to psychiatric symptoms, to depression, and also to neurocognitive impairment. I think it is important to search for similarities and also differences with other clinical models beyond the post-infectious syndrome. And here, the model of cancer, patients with cancer, because we know that the brain fog is in fact very similar to the chemo fog that is reported in patients with cancer, with possible common immunological mechanisms induced by the tumor or induced by the treatment. And I mentioned this study of my colleagues from Genoa, Italy. They found specifically on the frontal lobe a very similar profile of PET hypometabolism after CAR T-cell therapy, suggesting shared cytokine-induced inflammation in the brain of patients. Other models to consider are, of course, the model of functional disorder. Here is an example of functional deconditioning of the lockdown, but also the model of psychiatric disease. Probably I can start by clearly and strongly disclose that, of course, we know the neuroimaging brain impairment of functional disorders and of psychiatric disorders. And it is very different to the brain impairment we see in long COVID. It is not a theoretical knowledge. It is not a conceptual knowledge. It is a clinical knowledge, because every day we explore patients with severe disease, for example, with cancer, patients that are depressed, patients that are stressed, including PTSD or SSD, somatic symptom disorder, and the profiles are very different. This study, it's a study we conduct in approximately 500 patients to explore the brain impact of functional deconditioning on the brain during the lockdown. We found a brain impact, but with a very weak overlap in comparison to the very specific impairment that was described in long COVID. And I add also the model of fibromyalgia is a good model for functional disorder. of course, I believe it is a brain disorder, but there are no brain PET abnormalities in metabolism in this patient. It is, in my view, it is not the same story. Perhaps not the same stage, the same step. They are not at all the same profile using PET imaging. Abnormalities in these patients are found on activation, not on resting state, and using functional MRI and not using PET imaging. It is, for me, a different story. We have now a systematic review. This study, 90 study, PET study, MRI studies, and autopsy. And the most consistent findings was this impairment of this specific network from the olfactory region. Among all these studies, it is crucial to mention this study from London, from the UK Biobank. It is not PET, it is MRI. And it is a longitudinal follow-up before the pandemics, before the infection. So the infected patients are compared to non-infected patients, but we have, the authors had the data of the brain MRI before the infection. And they found a very similar brain impairment. It is a gray matter loss, an atrophy, within the system connected to the olfactory region and correlated to the symptom. It is very important because it is not metabolic, it is not functional, it's not the perfusion, it is structural, it is morphological. And this study also demonstrates that the impairment of the brain is not a predisposed state, because the authors had the brain MRI of subjects before the infection, and the brain MRI were normal initially. These results are confirmed on this more recent study. Again, MRI, so atrophy, correlated to symptom, exactly the same brain network connected to the frontobasal region, the olfactory region. We have now several PET studies in glucose metabolism that confirm the results of this impairment of this network from other groups. Here it is a specific study in out patients. They found a right hemisphere predominant hypometabolic profile, but involving the frontal lobe, the olfactory region, the temporal lobe, the limbic system, the amygdala, the hippocampus, and again, correlated with symptoms, correlated with fatigue, correlated with cognitive deficits. And I mentioned this more recent study, still in press, but accepted from the group of Paris, the Department of Nuclear Medicine from my colleague Aurélie Casse, Laurent Rosenblum, Marie-Odile Labert, with a collaboration also of Dominique Salmon, which is here present, neurologist Thomas de Brucker, and they found exactly the same profile of brain impairment, it's PET, metabolic imaging, at individual level and at group level, again correlated to symptoms. We have now published the same results in a short series of children with long COVID, with exactly the same profile of brain impairment. You have the 3D view. They are very similar between adults and children with long COVID. It is a more complex methodological study. It is an extraction of network, but it is, in my view, important. In acute COVID, we found an hypermetabolism, an increase of metabolism in the same region, showing afterwards hypometabolism at the stage of long COVID. And this transition on the same region from hypermetabolism to hypometabolism mirrors other transition, the one of disimmune encephalitis, for instance, and supports the hypothesis of a neuroinflammatory disruption followed by hypometabolic sequelae. Of course, we need now a longitudinal study, follow-up of patients to confirm that patients with clinical recovery have neuroimaging recovery, brain impairment recovery. It is not clear yet at this step. I show you this study. It is not prospective, it is retrospective, and the inclusion was in patients with severe symptoms, with persistence of symptoms at the 2 time point. And you see that the persistence of symptom is associated with a persistence of brain abnormalities. Again, the 2 time points are very similar, a very short improvement in the brainstem, in the cerebellum, without worsening. It is important, without worsening, but it was patients with a severe presentation. I had this last study, or next study, it's still a preprint. We believe that the clinical recovery for the brain, the clinical recovery of long COVID is in fact a brain adaptation of the network. It is a reorganization of the connectivity, probably supported by rehabilitation, and certainly more in younger patients with cognitive reserve, with plasticity. We have now some recommendation. It is not from clinical societies, it's from neuroimaging nuclear medicine societies, both the American Society and the European Society. We have 2 indications for the metabolic PET imaging in long COVID. The first, of course, the workup of differential diagnoses to exclude, for example, a neurodegenerative disease. The profile are different in older patients, in case of atypical presentation or worsening, but also to make the cerebral, the brain accountability. Is there or not a brain damage in the brain of patients, which is, again, probably certainly not the case of all patients of long COVID. So it is not a biomarker, a signature of long COVID. It is a signature of subgroup of patients with long COVID with a brain impairment. To finish, I would like to share with you this clinical knowledge. It is only an individual example in PET imaging, to share with you these obvious differences between functional disorders, psychiatric disorders, and long COVID. You have a series of examples of patients, here depression, a brain that is very metabolic, and you see, obviously, the difference, visually, the difference individually between this functional disorder, this psychiatric disorder, and long COVID. It is not the same story. It is not the same story. Here, long COVID. I give you 2 examples, including an example in pediatric. So to conclude, of course, all these studies have a lot of limitations. Agree, but they showed a specific brain PET profile in a specific network of region, the same in adults with long COVID, in children with long COVID, correlated to symptom. It brings a rationale for brain substrates and of patients' views, of patients' complaints, with certainly an individual relevance with a biomarker value, again, not to diagnose long COVID, but to identify in some patients, in a subgroup of patients, the brain impairment of long COVID and to make the differential diagnosis. These findings are consistent with the hypothesis previously made on post-infectious syndrome, systematic review, and this very important study from the UK Biobank with this comparison before and after the outbreak. The hypothesis is a network disruption with early diffusion of inflammation, perhaps diffusion of infection, followed by hypometabolic sequelae at the stage of long COVID, with certain therapeutic implication for early intervention. And the main hypothesis, it is probably the specific signature, the specific impairment of the metabolic unit of the astrocytes of the glutamate neurotransmission because of neuroinflammation and microglial activation. So to conclude, the functional impairment of metabolic brain PET imaging does not explain at all a functional disorder or psychiatric disorder, cannot be used to justify this diagnosis, but it also cannot rule out this diagnosis in association with the organic, the lesional component. Thank you for your attention. I want to thank my team, patients, relatives, and our collaborators. Thank you.